So I'm speaking on behalf of the Nutritional Risk Assessment Unit of the French Agency for Food, Environmental Health, and Occupational Health and Safety. So first I will talk about our mandates and objectives, and then I will talk about our method and the challenge we face to integrate epidemiological studies, our graded conclusion, and next steps. So briefly, the French Ministry of Health asked ANSES to to assess the scientific evidence in order to update the food-based dietary guidelines, which led to new dietary guidelines for adults in 2016 and new dietary guidelines for infant, children, pregnant, or lactating women and older adults in 2019. Then the question was asked for the individuals following a vegetarian diet. So we created a working group in 2019, and here you can see members of this working group, and you can see that we have epidemiologists, physiologists, and medical doctors that are all specialized in vegetarian diets. So the objective of this working group was to, and is still ongoing, so it's still to assess a potential epidemiological association between different types of vegetarian diets and health outcome using systematic review, and then using consumption data from different types of vegetarian diets in France using the NutriNet cohort, and composition data of food consumed by vegetarians using our SQL database. We will inform a mathematical optimization model under constraints that will allow us to establish dietary guidelines for these different types of vegetarian diets. So I will briefly explain our systematic review protocol by showing like a general analytical framework. So first, the population of interest was basically everybody, so children, adolescents, pregnant or lactating women, adult and older adults, that were consuming a diet excluding all or part of food of animal origin with a threshold for consumption of animal flesh of once a month or 10 grams per week. And the comparator was a diet including animal flesh or other type of vegetarian diet excluding other food categories. So we were not selecting specifically health outcome. We really wanted to see all the relevant health outcomes. So we have a long list. And we also identified for each health outcome key confounders that may have an effect on the association of interest and mediating variables. So here you can also see the key definition of the different type of vegetarian diets. So then we decided on some inclusion and exclusion criteria that are necessary to be able to select the publication in a systematic manner. So we decided to only include randomized controlled trial, non-randomized controlled trial, prospective cohort study, and case control study. And as the food-based dietary guidelines has to be applicable for the population living in France, we only included study conducted in a country with a similar human development index. And also, as it's intended for the general population, we only included study that were looking at healthy or at-risk population, but not study with an entire group of sick people. So the exposure had to be similar to our definition. The paper had to be published in a peer-review article. We didn't have any publication date limits. The size of the study group had to be above 30 or had a power calculation showing that the sample was large enough. And it had to be published in English or French. And for two types of health outcome, for mental health, we decided to include a retrospective cohort study. And for nutritional status, we agree also on including cross-sectional study, as we were really looking at the circulating nutrient level at a given time point. The rest of the inclusion criteria were the same. So with that, we developed a literature search strategy using keywords that were really focusing on the exposure. And we search on PubMed and Scopus. And we dually screen each article by reviewing title and abstract first and then full text. And we also conducted a manual search to identify articles that may not have been included in the electronic database. This manual search was conducted by looking at the reference that were cited in other systematic review or meta-analysis. So here you can see our Prisma chart that showed that we also had quite a vast amount of literature, and when we removed the duplicate, we had 10,893 articles, and we had to exclude a lot of them at the title and abstract level. And we ended up with 538 articles, and we found 7 articles using the manual search. And at the full text level, we had 545 articles. At the end, we included 131 articles. So here, this graph is showing you the type of study design we had per health outcome. And you can see that we mostly have a prospective cohort study. We had 57 prospective cohort study, 2 case control study, 1 RCT, and 1 non-randomized control trial. And for these other 2 specific health outcomes, we only had 1 RCT and 68 cross-sectional study for nutritional status, 3 prospective and 1 retrospective study, and 1 non-randomized control trial. So when we finished including all those papers, then we extracted the important data, and we also assessed the risk of bias, so using different tools depending on the design we had. So there is an issue, but it's the ROBS2 tool that we used for control trial, randomized control trial, then the Robbins I, and we also use the risk of bias for nutrition observational study tool for all our prospective cohort study. So as it was said before, it's a tool that was established by the Nutrition Evidence Systematic Review team of the US Department of Agriculture by making modification to the Robbins I, and a preliminary instrument that was designed to assess risk of bias of non-randomized study of exposure. And these modifications were made to ensure that the tool was applicable for observational study of food, nutrition, and public health. So we still, even though those risk of bias tools are very useful as guide for the reviewer, and they really allow us to be consistent and systematic in the way we do our analysis, we still have some challenge. For example, regarding bias due to confounding, it created a lot of discussion among our working group to make sure that what we define as the key confounding variable were actually key. For example, it was difficult to assess the impact of not adjusting for family history. As we know, family history is going to have an impact on health outcome, but we don't know the relationship with the adoption of a vegetarian diet. We also often, regarding bias in selection of participants into the study, in all the studies that we had, people were already vegetarian while they were recruited. So the exposure never started at the start of the study. Then regarding bias in classification of the exposure, often the authors do not give us the information on how they identify vegetarian diets, or they don't necessarily define clearly what's a vegetarian diet for them. And regarding bias due to departure from intended exposure, the diets was rarely assessed during follow-up. It was only the case, I think, for the EPIC cohort. And then for the bias in measurement of outcome, we had several health outcomes that were self-defined. And regarding bias in selection of reported results, often we didn't have any study that were, for example, registered on clinicaltrial.gov, so it was hard for us to assess if there had been some selection of reported result by the author. So then we assess the strengths of the evidence using also the grading rubric from the USDA Nutrition Evidence Systematic Review Team. So they have these 5 grading rubrics. They assess risk of bias, so the systematic error assessed with the risk of bias tool. Consistency, so the similarity in the direction and magnitude of effect across the body of evidence. Directness, or the extent to which studies are designed to directly examine the relationship between the exposure, comparator, and outcome of primary interest. Precision, or the degree of certainty around an effect estimates. And generalizability, and for us, it's whether the study participant, exposure, comparator, and outcome examined in the body of evidence were applicable to the French population. So with this tool, you can grade the strengths of the evidence from not assignable. It's when you cannot draw any conclusion due either to a lack of evidence or evidence that have a severe limitation, through strong, when you have a strong body of evidence and you have a level of certainty in your conclusion that is pretty good. So all your studies are of very good quality. So even though we had all these tools, the working group also decided to create a decision chart or decision tree to be able to be consistent in the way they were writing the conclusion. So if we had 1 or 2 studies that were independent cohort of low quality, as assessed by our evaluation of risk of bias, the grade was not assignable. But if we had 1 or 2 studies, independent cohort, but of good quality, then the grade was limited. And the arrow that you see in the middle are more to help us guide the writing of the conclusion and regarding the direction of the association. And if we had more than 3 studies of low quality, the grade was still limited. But if we had 3 studies of good quality, then the grade could be of either moderate or limited. So it will be moderate if we had a significant and consistent association, either that showed a lower risk or an increased risk. And if we had no association, then it was downgraded to limited, as we can really prove that no association or no proof of an absence of association. So here you can see our global decision tree. So now you can see that most of our conclusion statements were graded limited or not assignable. So we have a majority of limited. We had 1 conclusion, I don't know if you can see it properly, that is dark green, that was assessed moderate for the health outcome diabetes. And the working group is currently drafting a conclusion and assigning grade for nutritional status. As I say, we have 68 cross-sectional studies, so it's quite a lot of work. And at the end of that, our opinion and report will be revised and validated by our Human Nutrition Expert Committee. So it's another group of experts which include 20 members. And after the validation of all the epidemiological data, we will use those epidemiological information as well as consumption data, nutritional reference values, and contamination data that will be informing what we call our optimization tool that will allow us to establish food-based dietary guidelines. So thank you for listening, and I will be pleased to answer any question if you have any.